Hello, I'm Dr. Alice Liang, and I will be moderating today's presentation. We are very grateful to be partnered with the Office of Lifelong Learning, or L3, who provide much of the technical and logistical supports for these rounds. We acknowledge that we are on traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. So I'd like to now introduce Dr. Sophie Flor-Henry. So she was born and raised in Edmonton, which she indicates is always a joy to come back to. She completed her medical school at the University of Calgary, her psychiatry residency at the University of Toronto, and then returned to the University of Alberta for her subspecialty training in child and adolescent psychiatry. And upon graduating, she moved to the Yukon, where she now lives and works. And thankfully for us, she remains connected to our University of Alberta Child and Adolescent Psychiatry program as our rural rotation coordinator. And that's a joy for us. So welcome.
Okay, thanks for that introduction. Sorry for the slide issue. So like Dr. Leon said, I am Sophie. I'm a child adolescent psychiatrist, and I'm here mainly to talk about my experience working in the field in the Yukon. So I want to acknowledge, recognize, and respect that I live and work within the traditional territory of the people of the Kwanlin First Nation and the Tonquichan Council. I hope you guys can see the bigger screen because this map is going to be really tiny otherwise. But there are 14 First Nations, and the map kind of outlines the territories of each one of them. And as well, there's places where people are living, so we call those the communities outside of Whitehorse, which are kind of like all over this map, but we'll talk about the communities further on in the presentation. Are you guys seeing my mouse right now? Or no?
No, we can't see your mouse.
Oh, what about here? Or no?
Yes.
Yes. Okay, perfect. Okay, perfect. So Whitehorse is just down here. So these are just the disclosures. So I don't have any relationships with financial sponsors. I don't receive any honoraria, consulting fees. I have no patents. I'm not receiving any funding for speaking today. As Dr. Leong said, I am a member of the Grand Rounds Committee, so I am involved in the organizational and planning processes. And there's no identified sources to mitigate that I'm aware of. So really my goal for today was to share some of my experiences working in more remote and rural communities, knowing that the Yukon itself is very specific. I think there's some shared challenges and experiences working in rural remote communities in general, but also each community has their own very specific identity and strengths and issues as well. My goal is to also highlight barriers to care and increase understanding of challenges working in these areas, and to discuss ideas of how to improve care in these communities. Where is the Yukon physically? So it is up here. I get a lot of people that also get confused if I'm working in Whitehorse and Yellowknife. So it is Whitehorse in the Yukon. It's about a 22-hour drive up this highway. And I'd say once you pass around this area, Fort St. John is really, really beautiful. It's also not that far in terms of flying distance, about 2.5 hours. The local airline is Air North, which everyone very much loves and is a faithful customer to. but they do direct routes. And so they will always stop by Edmonton and Calgary and kind of just rotate which city they stop at first. But if ever anyone wants to come to visit, that is the way you get here. Where do I kind of work physically? So I guess in general, like the Yukon is around 25% First Nations. The population of Whitehorse itself, which is where I'm mainly based, is 28,000 people. Yukon as a total is around 43,000 people. I am based out of Klondike Medical at present, which is a clinic where pediatrics is also working, which is really, really helpful for me. And I work very closely with the pediatrics team. And there's many family doctors that work in the clinic too. And family doctors are really essential to care here and really run most of the healthcare in the territory. This is a picture of Whitehorse General Hospital, which is also where I consult. I mentioned a little bit of the community. So like I said, we talk about places that are outside Whitehorse and refer to them as the communities. I did get a question about like, what is it like to work in those places? For example, Old Crow, which is up here, and Mayo, which is, I'm trying to look at the map down here. And I would say like, it's definitely challenging. I do my work through like virtual visits, so telehealth or doxy, as well as indirect care and consulting. The pediatrics team here is really wonderful, and they do outreach work to these areas. So really they are on the ground and they visit all the communities, including Old Crow, which is a fly-in only community. And so they're really helpful for kind of identifying clients and families who require further support. They're very, very competent in really basic mental health concerns and can deal with majority of issues. But if they see someone who's requiring psychiatric support, then they refer to me. In a lot of communities too, they have health centers which are run by nursing staff, NPs. Some communities do have family physicians who live there or else are visiting. And so that can be a primary point of care, as well as are able to send referrals. So I actually haven't really seen anyone from Old Crow. I think there's a lot of, just by virtue of distance, right? It's very hard in terms of accessing care. I do see people from many other communities, the common ones being Watson Lake down here, Dawson City, Mayo, Carmax, Carcross. But yes, it is kind of, people are quite spread out, and it is hard to get services and when you're living farther away. Our team is really, really great here. So I am the only child and adolescent psychiatrist living in the territory. There is another child adolescent psychiatrist who works here, Dr. Willow Jenkins. She's actually based out of the United States, but she's been working and providing service to Yukon for, I want to say, around 8 years. I really value her as a colleague. She flies up around once every 2 to 3 months and provides kind of a week of service, and is also available to her clients through telehealth. But it's very helpful for me to have another child adolescent psychiatrist here who also understands the community. I already mentioned the pediatrics team. They're really amazing. There's 4 of them on contract here, and they work 1 week at a time, rotating. And they're very competent with regards to mental health and provide really excellent care. And we work very collaboratively together. We do have a social worker and mental health clinician attached to our clinic, and she is super, super helpful as well. She mainly helps us with parenting support, helping navigate our complex cases, helping also case managing support young people who are in treatment outside of the territory, and she helps liaise with community supports. Adult psychiatry, there's also a team here, and for myself, they provide really great collegial support, and also we work really hard together in terms of trying to address systems issues in the Yukon from a psychiatric perspective. And there's, of course, counselors and therapists, which provide like backbone for a lot of mental health support in the territory, as well as a dietitian. There's only one who sees younger people, and so she's usually stretched thin, but in terms of our clients with eating disorders, she's really essential. I will say this team has grown a lot. Like pediatrics only started like being here around 5 years ago versus being mainly a visiting specialty. And I've only been living here for the past 2.5 years. So really the team has grown a lot recently. Who and what do I see? It's kind of everything. I think virtual, like you really have to be able to be adaptable and just see whatever people are needing help and support with. So the range is from infant preschool to transitional age. I do ask my colleagues for a lot of support with infant preschool, as some of you will know. And I do see up to the age of 25, although I will say most of my transitional age are around 18 to early 20s. I see, as most others will also see, in child adolescent psychiatry, neurodevelopmental disorders, behavioral disorders, eating disorders, mood, anxiety, psychosis, substance use, lots of trauma, and gender diversity. I will also say that something that I think is a little bit unique is there's a lot of people that move in and out of the territory. And so that is also like, it's not like a unique population per se, but it is something that I've noticed. A lot of young people and families will move in and can move out of the territory very quickly. I'm going to talk now about some challenges in terms of working in the Yukon, so not necessarily close to a tertiary center. And I think some of these challenges are not going to be unique to the Yukon as well. So like a lot of places, we do struggle with a lack of primary care. For me personally, like I'm very lucky to be so well connected to pediatrics. So my pediatric clients who don't have any family physician, if they're needing medical support, pediatrics is definitely always there to help provide that support. It is harder with adult clients who have no family physician. At the moment, there's no walk-in clinic in town after one of the family physicians left the territory. And so for those without a family physician for kind of any medical concern, the only way to get kind of care is to go to Emerge, which is not a great use of system resources for sure. Like many places, there's just a family physician's shortage and there's really long wait lists. So the find a family doctor list, I think, is years long. Some people have been on. For myself, if someone does have a family physician or is seen by pediatrics, I do ask that the referral is through their physician. If someone has no primary care, no other physicians involved, then I will just see them directly. So the referrals can come from social work, counselors, etc. The communities I've talked a little bit about already. I think it can be very isolating, both like physically in terms of there's not always like land access available. There tends to be a lack of resources as well, so, and high turnover. So when I say these things, I kind of mean that, for example, like the nursing staff, the physicians, the counselors, the social workers that can visit these communities, it's like often very difficult. And if someone is not permanently based in the community, I think people can become quite burnt out and overwhelmed. So for example, like a counselor may visit 2 or 3 communities and be there for maybe a week or 2 at a time, and then travel to the next community. So there's not always a permanent counselor there. Same with social workers. They're often moving to various communities as well. And so I think for the people living in the communities, it is hard to build trust. And there is a high rate of turnover, I think, just because it is a very hard job as well. And so, you know, I have a lot of clients who are not very excited about seeing a counselor who may or may not be there in 6 months' time, for example. I think it's also isolating too for young people in general in the communities. Like, they are very small for the most part. And I think if something happens where some rumor has spread or you've gone into a conflict with someone, people do tend to know your business. And I think it is hard to kind of find your new network of people that might be supportive. Staffing shortage extends to other areas as well. Like, in my opinion, there is a school crisis. Like, it's really hard to find educational assistance. So a lot of young people who are needing more support in school are just unable to get it. Family Children's Services is very overwhelmed, it seems like, and are unable to provide a lot of support. And respite workers, like my families who require respite workers, they're able to get funding. The issue is not the funding, but there's really no one available. So that makes it very challenging as well. There's a general issue of trust, which is difficult. Trust is, I think, hard for First Nations people due to a history of trauma, a history of experiences with the healthcare system, as well as ongoing experiences of racism as well. And also, you know, like I spoke about, the frequent turnover of staff also makes it difficult to develop a relationship of trust. And then I think this is also not unique to Yukon, but services can be quite siloed. So there's resources that are frequently changing services, changing inclusion, exclusion criteria, services being created, but there's quite poor method of communication. So it takes quite a lot of work to find out what services are still running and what exactly they're providing. The hospital itself, I find quite challenging. There is very little experience with children and youth mental health in general. And so we really do try to do as much outpatient support as possible. When people are admitted to hospital, it's mainly for crisis management and support. And it is really difficult because there's no appropriate space for young people who need to be in hospital. So if someone's admitted to hospital for safety concerns, you're then put in a position where they're either in a regular hospital room, which is not necessarily safe for someone in an acute mental health crisis, or if you're looking for the physical safety of the room, those really only exist on the adult secure medical units, which is the adult psychiatric unit, which is not a good place for many young people. I will say, in hospital, there's also no programming available. So if someone is in hospital, it's kind of, you're just in a room with not much available from a psychotherapeutic lens. And if people are needing longer admissions to hospital, we do try and transfer them to a more appropriate facility with these services available, but transfers are very, very difficult. Lots of systems are, I'm sure, over capacity and very busy themselves, but it puts us in a very difficult position as well. I was asked, what is it like to be a solo practitioner, and is it scary? The answer is yes, sometimes. I mean, I do deal with most of the issues come up, but I think it can be very isolating if you aren't really deliberate in building and maintaining relationships, which I make sure that I am. Something that's also hard is that you really don't get a lot of feedback. So for example, if I see someone as an outpatient and then they're admitted to hospital, I'm also the consulting person in hospital. And so you have no one else kind of providing a consultation if someone's in emerge or they're admitted. And so that makes it quite hard in terms of, like, would someone else have had a different perspective? Would someone else have had like a different differential or management idea? Another question someone had brought up to me was, how does call-in coverage work without burning out, and how do you make it sustainable? Which is a pretty hard question. And I would say, like, for me, like, it was like interesting because I moved straight from residency where there's very clear call expectations in terms of like, you're working this many shifts, this many days, this is where you're working, and that's it. Whereas when I moved here, it was kind of very vague and just like, what do you want call to be? And so I received like really wise advice from colleagues that were already working here around setting appropriate boundaries and acknowledging that if it wasn't working out, that things could be tweaked. So, oops, sorry. So I started and has continued to do Monday to Friday daytime call coverage. Like I said, I do try and handle as much as possible as an outpatient given the limitations in the hospital, but some people do just need hospital admission. But yes, if things can be seen as urgent outpatient consults, we definitely try to do that. And to be honest, like Monday to Friday daytimes has been okay. I am not like the most responsible physician or MRP, which I also think has helped make it sustainable. So when young people are admitted, they are admitted to the hospital's program and I consult. And I think that's really been really helpful for me personally because it just adds more layer of certainty to my life, say. Otherwise, see if someone was admitted over a weekend, potentially you need to cancel a lot of plans. Say you wanted to go outside of the city for the weekend or plans to do so, there's really no cell coverage and it's not feasible to do that. So it's been really helpful to provide more kind of certainty for my life personally. I will also say something I do appreciate a lot, which is also helpful that Dr. Jenkins is around, is that when I'm away, she provides phone support. And so while that's not the same as having someone on the ground, it is really helpful to know that there's someone who is able to provide support to the teams here. The next point I had is lack of access to intensive programs. And this point is very, this is very difficult, I think, for us as care providers, as well as for young people and their families. I think that as a team, we provide really, really great outpatient care, but some people just need more than that. And so I talked about the difficulties of kind of inpatient treatment programs and accessing them, but even people who need just say like day programs, there's no day program available in the Yukon. And it is hard to get access to these programs outside the territory. Many programs will just say they're not accepting Yukon clients. And so we're really limited in options. And I will also say that when people are able to get to say like a residential type program or a family treatment program outside of territory, while there is funding available, it's often very hard to get the kind of family support that is needed for treatment. You can imagine being away for 1 month or longer is very difficult for families, both from a financial perspective. So there's funding for the actual treatment itself, but things like families need to pay their mortgage, things like taking leave off work are just very disruptive and not feasible for many families. There's also kind of difficulty and utility of going like far away from outside of territory in terms of making sure that the skills that are learned there are applicable to young people's lives back at home. And I do imagine that it's very triggering, particularly for our First Nations families needing to go outside of the territory as well. And so I think, that's a huge gap in the care that we are able to provide. The dream, I think, locally would be to have a local day program, but we are not there yet. And I also talked about changing resources. It's just really difficult to keep track of and access properly. what else do I do? So I think part of the joy of working somewhere like the Yukon is you do have a lot of flexibility and you can do a lot of different things, which is really rewarding and helpful in terms of building variety in your work and career. So in terms of the hospital, what's exciting is Whitehorse General is building a new mental health unit. So myself and the adult psychiatry team are helping advise that. And we do help with advise hospital policy around psychiatric issues, as well as identifying a lot of issues. Advocacy is a big part of our role, and I think there's lots of room for improvement, and people do want to create a better system. And I think it's really rewarding to do that. And so, for example, there's lots of advocacy on my end with regards to getting access to more intensive treatment programs and hopefully a day program in the future for the territory. In addition, I've been kind of working on making sure that there's enough therapy groups and services that are evidence-based that are available to our young people. Our social worker here attached to our clinic has collaborated with a local mental health team to create a child anxiety group, which had not existed before. And so that's really exciting and going well. And we're hoping to expand services like that. I provide education to nursing staff, particularly at the hospital, continuing medical education to the local physician community, as well as to counselors. Looking at services, including improving delivery of clinical services to specific populations. So for example, working with other clinicians around how are we delivering or how do we improve delivery of care to, for example, those struggling with gender diversity issues or eating disorders, as well as collaboration with other local agencies, so therapy teams, Council of Yukon First Nations, etc. And as already mentioned, I do stay connected to U of A, which I think is very valuable for myself. I am part of the RPC, the Grand Rounds Committee, and I'm working on increasing elective experiences, both in Whitehorse and the Yukon, because I think it's awesome, but also more locally in Alberta. And I think kind of having these other areas of work has really been very exciting, and it has added a lot of meaning to my job in general. I had a fun fact slide up here. So the question I think I get asked the most is, in the winter, do you ever see any sunlight? The answer is yes. So I kind of just put the numbers here. So like dead of winter, you're kind of getting sunrise at 11:10 a.m., sunset at like 4:45 p.m. So you do get to see the sun, but it's very, very short. And I will say it changes very fast, right? Because you need to get all the way to June where you're getting long, long hours of sunlight. And even though the sun sets at around 11:36, I guess, p.m. last year, you still get light for a long time afterwards. And so the days are very long, which is very fun. It's just, it's often you will wake up at 4 in the morning thinking it's time to get up for work. I also get asked a lot about the weather. Whitehorse itself is pretty warm. Like it is cold where you will get a couple weeks of -40, but it is kind of in a valley and it is close to the ocean, which I think regulates the temperature a little bit. And honestly, it's pretty similar to Edmonton. Edmonton is not a warm place. And so it's pretty equivalent to Edmonton. Like I said earlier, cell reception can be hard if you're outside of the city. And so you really, especially in winter, need to be prepared with your car and emergency supplies if you are going out of town. Internet power can be super spotty. Heating is all delivered, so it's delivered on trucks. Usually it's either propane or oil. Shopping is not bad. I mean, Whitehorse, it is a city. There's a superstore, there's a Shoppers, there's an oyster house, I will say. So the shopping is quite good. Things like, there is always road access to Yukon, even in winter. And so usually there aren't a lot of supply issues. So of course, if a truck doesn't make it, no stores in town might have produce for a few days. And food does tend to go bad faster. But I think because of road access too, the pricing of groceries is is not significantly different than in the cities. The Yukon is growing a lot. So when the 2021 census came out, it showed that it was the highest population growth in the country, and increased by 12% since the last census in 2016. And you definitely can feel it. Like, I haven't been here since 2016, but it definitely feels like a growing place. There's more young families, there's more children, which in turn increases the need for services as well. It has affected housing prices, which are going up, as well as homelessness. And it is harder in general to build things here, right? So just from a supply chain, as well as finding people to help build. So I think those are big issues currently in the territory. And with just more people, I think there are bigger strains on the medical system here as well. The next few slides are kind of around how do we promote recruitment and retention in rural and remote communities, because it is a huge area of need. So this report came out of Carleton University. They estimate around 1 in 7 physicians will leave rural practice within 2 years, which is really short. And like I talked about, I think it's really hard when there isn't retention in terms of kind of building and growing services within a specific community, as well as building trust with the people who live in the community. So their key findings was recruitment based on rural origin alone is insufficient. And so while, people that are coming from rural areas are much more likely to practice in rural areas, we need to be thinking about people who were born in urban settings as well. Rural exposure is key for increasing recruitment and retention, and increased interest in future rural practice can shift urban-born perspectives on rural practice or lifestyle. Remuneration must be reevaluated. So rural GPs report willingness to receive lower salary in exchange for better administrative support. And I think, from what I could gather, financial incentives are good at the recruitment piece, but not necessarily helpful for retention, which is difficult then. They suggest that more attention should be paid to social dimensions. So spousal influence, resources for physicians, children's, and lifestyle. Strong community support and appreciation encourages retention, and that multiple different recruitment and retention methods can be implemented and adapted. So I think, in general, the strategy has been to increase kind of recruitment and financial incentives, but that's not been helpful long-term in terms of retention and ultimately having more stable medical services in rural communities. These are just 2 other kind of studies that shared some ideas that are fairly similar. So financial incentives can help short-term recruitment, but not attention. Less than 10% of physicians serve rural remote areas, so over 20% of the population live in these areas. And kind of key areas, again, were like sense of belonging, integration, appreciation, social integration of partner and family, which I think is really important, a positive work environment, relationship with colleagues and peer support, and positive relationship from urban specialists who can understand the context when a physician or a clinician is calling for help. which is what I also hope will be helpful in kind of hearing me talk today, is I think it is really helpful for when people that are working in more remote and rural areas with fewer access to services are able to talk to a tertiary care center who understands the limitations, because really we try and do as much as we can as possible within the area we're working and kind of reach out when we do need support. And motivating medical students. And so the study was kind of saying that medical students who see like they are going to a community for an elective, they're seeing concerns regarding health inequities, and they see like their preceptor, their mentor involved and engaged and happy in their community is helpful for motivating them to consider rural practice. Like I said, the interest in rural medicine is greater in those of rural backgrounds. In general, though, they tend to be underrepresented in medical schools. And also to note, like most of the workforce are from an urban background, and exposure to rural experiences and training is really influential in terms of determining final practice location. And so for me, I think like a lot of those ideas make a lot of sense and fit. A lot of those studies are looking at family physicians, which makes a lot of sense. So it is a little bit different as a specialist. And I know there's a shortage of child adolescent psychiatrists like everywhere, including in cities and tertiary care centers, let alone in rural remote communities. I do think that it is really important to kind of increase exposure in training, and the idea of like, you know, even providing some kind of like collaborative support, because the physicians working in these communities are really, really competent, right? And so even forming a relationship and providing consultative care, but having a relationship with that community, I think can be really helpful and appreciated. Thinking back to like my own experiences, like I'm someone who did not think at all about working in outside of a city, outside of like working down south in a city close to tertiary care. And I don't think I would have like explored those experiences if I didn't know that they were available. So like in Toronto, the training program, there are experiences where you can go up north to Nunavut. And so I had a couple of electives and experiences up north there, which I would not have pursued if it wasn't just available through the program. And I think that was really important. And also to have like the option just to try things out. I do agree that, you know, having some familiarity, so seeing the place in some sense is really helpful. So even if you're doing a little bit of locum work, or you're a student and you're doing electives, or you're just traveling there, it's important to get a sense of what the community is like and if it will potentially be a good fit or not. If someone is single, I think there's certain considerations that go into that. If someone has a family, similar considerations. And I think it's important to make sure that is a good fit in order to address this retention issue. And I do think it's really important to have initial and ongoing support. So when I moved up to Whitehorse, one of my friends and colleagues had already been working up here for a year. So it wasn't, I wasn't like coming up here without knowing anyone and having no support. And that's been really helpful. And like I said, you know, you've heard me talk a lot now about kind of my high held regard for our team, which I think is really wonderful. And I don't think I would be able to do my job without them here, to be honest. And so I definitely do have that peer and collegial support, which I think is helpful for long-term sustainability. And I just wanted to say, like, awareness of flexibility with things. You know, a lot of these communities are really just looking for help, and I think are pretty adaptable in and of themselves. And so if it's something someone is interested in, I think just having the conversations of what would work and what would be sustainable can open a lot of doors. More specifically, I guess, for us and for Alberta is, I think many training programs are increasing expectations for rural remote rotation exposure. That includes like the U of A Child Adolescent Psychiatry program, and I know the General Psychiatry program as well. I do really strongly believe that we do need to make sure these training experiences are positive and have adequate supervision. I think a lot of these places are very excited and quite desperate sometimes to get support. And, as a resident going, like they might have the most experience in psychiatry, but I think it's really important to make sure that there's adequate supervision and it is a safe experience for our trainees. Usually there is like support and funding available. And like I said, a lot of these programs are just trying to make things work. And so I think it's always worth reaching out. Our PAP is a resource in Alberta, and I had spoken to them, and they're very much wanting to create opportunities for more specialist availability too that are needed in areas in Alberta. And in the Yukon, like there is a resident and medical student support program, which provides some funding if there's no coverage from the other program. And so it's been really nice. We have been getting more psychiatry residents coming up to Whitehorse. And I want to say people are always welcome to come up here for electives. We really love having students and think it's a great experience. And right now we're just working on also trying to figure out more rural experiences in Alberta and places that are underserved in Alberta that could be good training opportunities. I guess like in summary, why I love it. Like I said, it is a very varied experience, both like in terms of the clinical work, which is a very wide range, as well as non-clinical work. It's really rewarding to work with the young people and families that I do, along with like all the allied health teams and agencies that are in the territory and outside the territory. Like I said, and I still do, like really believe I have wonderful colleagues and we work really well together, which is like a key foundation of making work sustainable. And I think, when I said I also make sure to be deliberate around maintaining relationships, that includes my colleagues in Alberta as well, because I think that's also a huge piece of making sure that you are still up to date, still connected to a community, and has also been very important to me. In addition, I just like the Yukon is also just a beautiful place to live and it's very fun. And people who know me have also know that I say come visit anytime because it is really great to visit. And I got a request for some pictures, so the rest are kind of just pictures. So there's really lots of very fun experiences to have. I usually do say to people, you're visiting to come in the summer where the days are long and there's lots to do, or the winter, probably like February is good where you can do all the snow sports, and your days are longer in December, so you have more of a time frame to do things in the day. This picture is when we took like a little, like only 2 passengers could fit on this plane, and we flew up in Kulani Park, and this is like the only company they're like grandfathered in, and so they can land on this glacier up here. It's the largest non-polar ice fields apparently, and back here kind of covered is Mount Logan, so tallest mountain in Canada. So that was very cool. These are just camping pictures, so tons and tons of camping and hiking. This was in Tombstone Territorial Park, which is close to Dawson City, so northwest, but very beautiful. There's lots of camping and hiking as well, just like 20 minutes outside of Whitehorse, so you can go close, you can go far. there's lots of activities to do. So I would say since I moved here, I like took a canoeing course. I'm not a canoeer, but hopefully we'll get better. We can go paddle boarding. There's tons and tons of lakes around. Trying to get into fishing, caught a few fish, but I'm not that good yet. There was a local ski hill, which is like 10 minutes from town, and there's lots of backcountry skiing and cross-country skiing here as well. Dog sledding, winter camping. There's actually a wood stove in here, so you're like pretty toasty when you're camping. And snowmobiling, like lots of places to do all the things. And everywhere is just very beautiful, I would say. I like this picture because this is just a 10-minute walk from where I live. And so that's a really nice view. And it's good for my mental health, I would say too. And that's it. I talk kind of fast, but open for any questions. And thank you for listening to me.
Thank you, Sophie. Before maybe we get to the Q&A, and I'll thank you, and then we'll just a bit of housekeeping before Q&A. So, thank you, so much for your engaging presentation that really highlights the challenges, but also rewards of working in a more rural, remote area like the Yukon. And yeah, we really appreciate those gorgeous pictures as well. That's definitely a selling point. So I just want to remind people that these rounds are accredited by the Royal College of Physicians and Surgeons of Canada, as well as for the College of Family Physicians of Canada for live attendance. And for the Royal College, this is a self-approved group learning activity under Section 1 for up to 1.25 hours. And for the College of Family Physicians, this is a 1 credit per hour group learning program for up to 1.25 main pro plus credits. And also, as another reminder, our April, so that's next month's Child and Adolescent Psychiatry Grand Rounds is hosting a speaker from Australia, Dr. Kazia Kozlowska, who is going to be speaking on functional neurological disorder. And because of time zone type requirements, we need to change of our rounds to Wednesday, April 12th at 4 p.m. So I hope everyone in the audience will be able to note that in their calendars. And the registration for this session is the same as in previous sessions. And we will be sending out a poster soon about our March and April session. Sorry. Yeah, April is after March. So yeah, we have a different presentation and then the April one. The March one is actually on CASA programs. So that should be an interesting one as well. So yeah, we would appreciate you taking time to complete the evaluation form. And you can do so by either scanning the QR code or going to this link. And just to let you know, as Sophie mentioned, she's on the Grand Rounds Committee as well. We do actually read over and review all of the evaluations and comments. And these actually help us to develop future Grand Rounds topics, as well as ways that we can improve Grand Rounds. And yeah, so please do fill it out. And I guess we could move on to the Q&A section. So currently, I don't see any questions right now, but I can always start and more questions may come in. So one of the things that I found interesting is that you have one child psychiatrist who kind of flies in and does more like hybrid, type work while you're there, more or less, in a full-time permanent. So, and it sounds like you work, very well, together. And I'm just wondering, Do you have any, I guess, any advice on how, because I'm just thinking that for a lot of the, rural remote communities in Alberta, it might be more of a hybrid situation, as you indicate, where you might have some practitioners on the ground and then maybe, some who are, coming in, remotely, and how that can work.
Yeah, I mean, so like, I guess for context, so she had been coming here for quite a long time. And before I moved here, there was another child adolescent psychiatrist who was also doing the fly-in work. And so I think when I moved here, it was like just a lot more, we were able to provide a lot more service, right? And I think it is helpful, I think, for the community to have someone on the ground. I think there was a lot of struggle, especially given like if there's more complex kids, as well as like not being able to access more intensive treatment. A hospital can be really complicated and difficult to manage. And so I think that was kind of like what's been really helpful about having someone living here. I think like the hybrid models can work really well. Like I personally have really appreciated her support, and honestly just having a colleague also available, like I said. And so I really also like advocate like, yes, Dr. Jenkins is awesome, right? And so I think it is really helpful too, just to have her providing support. And I wouldn't see any reason why in other communities like that wouldn't be something that could like, I wouldn't see why that couldn't be something that would happen, like as well. I think it's not that difficult to integrate. I think like with all these things, you just need like really good communication. And so we've been kind of communicating too, to make sure that we're on the same page, that, someone who's seeing her is like, they're getting like similar care, you know what I mean? And so I think those pieces are really important too, to make sure that people are getting similar care no matter who they see too.
Yeah, and I agree that ideally, to have someone there on a continuous basis is much, better and desired care. But until we sort of get to that point, or if we get to that point, that having this kind of stopgap or transition where you do have some outside people being able to work with local people, like yourself, to just improve that quality of care and coverage for the physician, reducing burnout, etc. So it looks like there's some other questions that are now coming in. So the first question is, Sophie, this is from Dr. Caroline Hapshin. I also had 10 days in Nunavut when I was a resident. Please consult with us about infants and preschoolers whenever you need to.
That's amazing. Thank you. I've been asking Christina a lot, so I appreciate you guys a lot at Elm Tree.
That was more of an invitation to you then. But I would imagine, for some of the other child psychiatrists, like we have a couple in Grand Prairie, whether, that might be also something that, we can strengthen or make available. So Dr. Nair says no questions, but thank you, Sophie, for a great talk. And then, it looks like you have a colleague who is joining. So, hi, I'm a child and adolescent psychiatrist in Yellowknife. Yeah, our situation sounds so similar, and it sounds like they may want to connect. So nice to share ideas and experiences. Wow, I'm really impressed. I don't know how we, that's great that that Cap in Yellowknife is attending these rounds.
I'm sending my email right now.
Right. And then Dr. Sue, Kao Sue, who's also on our Grand Rounds committee, is asking, as the only pediatric psychiatric provider in the Yukon, how long is your wait list for non-urgent patients? And is there enough volume for more psychiatrists to join to share the workload?
my wait list is really good. Like so I would say for non-urgent, like I see most people within 2 months, which is really fast. And I think part of that is like really trying to work like collaboratively with family physicians as well as pediatrics team. Like we do a lot of collaborative care. So the wait list isn't bad. I think in terms of like having more like child adolescents specifically, like sorry, specifically child adolescent psychiatrists versus adult psychiatrists, because I know adult psychiatry is pretty stretched at the moment. I think it would be helpful in terms of when we're able to develop more programming, because like I said, I think the biggest area of need is not our current outpatient support, but it is like trying to develop like a day treatment program and then having care provided there. So I think it's kind of expanding as much as we can and then seeing what's needed from that perspective. But in terms of like currently outpatient support, we're able to see people like really fast and I think are able to follow up very quickly, which is amazing.
Yeah, I agree. I mean, it sounds like the outpatient is not too bad, but if you want to develop day programs and other or maybe some hospital coverage, that yeah, to have like more child psychiatrists, definitely there's a need and space. So Dr. Hapshin has actually responded that Elmtree actually has connected with colleagues in Grand Prairie already. And yeah, and it sounds like they're also inviting the colleague in Yellowknife to connect up with them. So that's great that these connections can be made. And then Dr. John O'Connor is saying, oh, how is it that you can be recruited to the Yukon when the likes of Fort McMurray has not succeeded so far in doing so, and that they're considered rural? So I guess if you have any, insider information.
I think it's going back to really looking at the factors that some of those studies said around retention, recruitment and retention. And so for like my experience personally, like I had known someone who was working in the Yukon already that was a psychiatrist too. And so that was helpful for me personally to have already that connection. And then I did 2 weeks of electives in the Yukon with the thought that like I might be potentially working here. And so that's why I'm thinking about training and opportunities available, like creating more experiences for trainees, for example, potentially to go to Fort McMurray, because I think it is hard to recruit when someone has never been there before, because that's really scary, as well as thinking about like the other supports that would be available. So if like a student went to Fort McMurray, had that exposure, had a great experience, was able to see what supports were available there, and also trying to ensure good fit, as well as like thinking about like community, both like professionally as well as personally. Like I know my partner personally was also very motivated and excited to move to the Yukon, so that's been really helpful. Like if my partner wasn't on board, then I think it'd be very difficult or wouldn't work out, right? So I think the secret is kind of more creation of these opportunities and training and kind of like really working hard with exposure and creating these like supportive environments. But we can talk about Fort McMurray if people have contacts.
Yeah, because I'm thinking that for you there was that personal connection as well as those training opportunities from Toronto and even here that was so important in terms of you at least even having this idea that hey, this is possible and potentially attractive. And so yeah, it sounds like some of these more rural areas having a let's say a psychiatrist even have a trainee with them, and then maybe speaking to their colleagues, especially the younger ones, about the potential opportunities and how engaging them in recruiting, it sounds like, is something that can be helpful. I'm just wondering, given that you are our U of A rural rotation coordinator, would you mind if some of the people on this call try to like connect with you in terms?
Can all reach out, no problem.
Yeah, it's nice to yeah, again, provide those opportunities and yeah, and then work on it from both sides, both the U of A and the remote site side. Okay, so Sharon Mohammed says, thank you for the presentation. You've convinced her. She needs to take a weekend trip to visit Whitehorse, beautiful sights, and thanks for everything that you do. And then Dr. O'Connor actually is giving you his email address to, yeah, connect and talk about recruitment to Fort McMurray, it sounds like.
I will send you an email.
Yeah, I'm just wondering, even for like, if a resident is doing, you know, let's say if they're doing a rotation in Grand Prairie, given that we don't actually have like a child psychiatrist in Fort McMurray, whether, you know, there can even be some remote telepsychiatry support. Because I know when I did my fellowship in Toronto, and I actually drove out to a more, I guess, suburban, area outside of Toronto, and I received my supervision from a child psychiatrist in Toronto. So I went out there on my own, and then I would talk to the psychiatrist every 1 or 2 weeks just to make sure, like, am I on track? Is there anything else, I should be thinking of, and just kind of building my confidence in terms of me being out there alone. And I'm wondering if maybe we can support some of our trainees if there's not necessarily like a child psychiatrist on site, because we know that, a lot of areas might not have a child psychiatrist on site, but if we can help them have at least the experience there and make sure there's a really supportive team and make sure they're well supervised enough, especially for our subspecialty residents or maybe more intrepid, general psych residents, that they could do okay with like strong remote supervision.
Yeah, I think that totally is fine and makes sense. And I know, I do think, especially as like if a resident is interested in like working in any community, I think it makes sense for us to support them in figuring that out. So I think, like, I kind of said, like, I think we should be flexible and adaptable, and you need to be those things in these communities anyways. And so I think we can definitely make those things happen. I think in all these things, like, just like talking about making sure, like you said, there is like good enough supervision so people aren't put in feeling in unsafe situations where they can't get help when they need help. But I think, like, for the most part, we can make things work for sure.
Yeah, and having a robust team around them helps too, it sounds like, including pediatricians and other adult psychiatry colleagues. So Dr. Lindy Van Riper is saying, thank you for doing the job you do and for being our rural rep on CAPS RPC. So lovely presentation and so good to see you. Yeah, we're all, really happy. It's like a bit of a virtual homecoming here.
Thanks, Lindy.
Okay, so it looks like that is the end of our Q&A. So Sophie, thank you for this inspiring and thoughtful presentation. And it sounds like more than one person is going to be in connection with you. So let's
awesome. That's amazing.
grow and expand.